Well, thank you so much. Thank you so much for this opportunity. I'm going to present a case that makes me think a lot about the way I practice, not about biologics and treatments, but beyond that. Beyond that, what Dr. Blauert mentioned about the art of medicine. These are my disclosures. Here's where I live, where I practice, and I invite you to come to my clinic just for one patient. For this patient, a 47-year-old man with psoriasis since 2010, with a PASI of 8, a body mass index of 29. Previous treatments include topicals, phototherapy, and methotrexate. Currently, he was not treated. And concerning cardiovascular risk factors, you can see no diabetes, no hypertension, no smoking, and LDL of 135. This is our patients. You can see his psoriasis, typical classic psoriasis in the elbows, knees, and the trunk. And we go to the clinic with the patient, and we are highly motivated dermatologists, and we want to evaluate the cardiovascular risk of this patient. So we go to guidelines. We go to the European Society of Cardiology guidelines, the American Heart Association, and we do the cardiovascular risk score, the calculator. Even we multiply, because we study, we multiply by 1.5, and our patient is a low-risk patient. This would be like a psoriasis patient with no comorbidities. Low-risk patient according to cardiovascular risk stratification. So apparently, we are with a healthy, happy patient. But now I invite you to see this patient with another lens, with the lens of us, of people who are interested in psoriasis, who study. So now things can change. We have an untreated psoriasis. Dr. Blauert mentioned before that the more PASI you have, the more inflammation in your vessels, the more cardiovascular disease you have, and the more mortality you may have. We have a high body mass index, which we know drives many comorbidities in our patients, especially cardiovascular comorbidities and others. Also, that LDL level, which his primary care physician said it was good for his age, is currently high. And then I asked the patient, what about your family history of cardiovascular disease? And he said, my father died of myocardial infarction at 57. So now the story changed. But this kind of patient sometimes comes to our clinic and we say, well, he's 47, we can wait. But are we sure that we can wait? Because if we go to the seminal published article of Dr. Joel Gelfand about mortality in psoriasis, when we go to the younger population, we can see that there is an increased risk of mortality in younger patients. So maybe it's not a good idea to wait. So what happened with our patient? Well, I am running a cohort study in my center. So for research perspective, we included this patient in the cohort we are doing in collaboration with Dr. Mera in Madrid. What we are doing here, we do angio-CT to every patient before beginning biologics, and then after a year, we do another deep cardiovascular phenotyping. So this is not the clinical routine that I do, this is only for research. But in research, many things happen, and the next day after including this patient in the research protocol, the cardiologist called me, and she says, Álvaro, how old is this patient? He has severe obstruction in his coronaries. You can see there 95%, 90%, and 90% in the coronary tree. With the angio-CT, you can see because his calcium score was 0. These were soft plaques, soft coronary plaques, what he had. And this could be something like just one patient, but I've had 9 patients out of 120 that we have included, all of them around 48 years old, so this is not a chance. So this patient was sent to the cardiologist, triple stenting, high-intensity statin therapy. Biologic therapy was started, and through this process, he was diagnosed with non-alcoholic fatty liver disease. So was this a success or a failure? Well, for the patient, was a success, but it makes me think a lot. Every time the cardiologist calls me with a patient like this, it makes me think about my practice, about what I'm not detecting in my patient if I'm not including them in this research protocol. So what can we do? One of the questions is, what about these cardiovascular risk scores that we are supposed to do according to guidelines? Are they capturing the cardiovascular risk in psoriasis patients? And we tried to answer this question in this article that we published in the European Society of Cardiology journal. And what we found here is that every time that you have a patient and this patient is classified of low risk according to these guidelines, almost 50% of them are actually at high risk. And why is this? Because these cardiovascular risk charts, they don't include inflammation, they don't include body mass index, they don't include many things, and also age. The age interaction plays an important role. So, and these are young population. So we need different things. Also, what about other organs? This patient was diagnosed, but was diagnosed with non-alcoholic fatty liver disease during this process. We tend to think that this non-alcoholic fatty liver disease is a risk for developing liver diseases, but what is actually known is that it's also a risk factor for cardiovascular diseases. And we published this in the Journal of the Investigative Dermatology, really showing that a psoriasis patient with non-alcoholic fatty liver disease is a greater risk of having cardiovascular disease, actually. And we need to see the patient overall, and that cardiovascular disease is not only about the coronaries. And then we had an untreated patient. We have been talking before about untreated psoriasis. And we wonder, does treatment of psoriasis modulate cardiovascular disease? Is this good for the patient? Is this bad for the patient? This is another question that we try to answer from the highest scientific evidence. We try to do a systematic review and meta-analysis of placebo-controlled trials. And here what we found was that there were some improvements in some cardiometabolic biomarkers, in blood-based cardiometabolic biomarkers. When we go to imaging biomarkers, there are like neutral effects. No worsening, but no much improvement. This can be because the biologists don't do it, or we need new biomarkers. We still need to elucidate this, but we are clear that we need to have our patients completely clear. Another question that I had is, who is doing what? Because I can think, oh, okay, this patient is being evaluated by his primary care physician or a cardiologist or an endocrinologist or someone else. So I'm sure that maybe this is happening because we are dermatologists and we don't have time for this. We try to do this in a national survey that we have done in our whole country, in Spain, a survey among dermatologists, rheumatologists, and primary care physicians. And you know what? 67% of primary care physicians did not consider psoriasis as a risk-enhancing factors for prescribing, for example, statins. Then we go to dermatologists, only 12% are actually prescribing statins, and the patient should be like in the middle. So we still need to know who needs to do what. So what can we do? I like this suggested approach by Dr. Garchik because it is more complete. It includes evaluation of cardiovascular risk in patients with a definition quite similar to the IPC definition of severity, to checking not only what these cardiovascular risk scores include, but also including body mass index, smoking, family history, and actually levels of LDL. They propose early statin initiation. And why early statin initiation and not other drugs? Where statins are a hot topic now in psoriasis, not only for the LDL levels, but also for the systemic inflammation improvements that they have shown in their pleiotropic effects. They have also shown reduction in all-cause mortality with no excess of adverse events. So we are developing now new initiatives trying to really make it easy for dermatologists to prescribe this, or at least to understand this and to try to solve this. Other initiatives that are now running is this from Dr. Joel Gelfand, who is testing a centralized care coordinator trying to fill the gap between guidelines and clinical practice. Going back to the clinic to finish, just what I wanted to show here is how we can move from an apparently healthy 47-year-old man to a multimorbid patient with high risk of cardiovascular mortality. And in conclusion, what we need are strategies to capture patients at high cardiovascular risk, and this could come with collaboration between different fields of knowledge. Thank you very much.
Thank you for presenting this case, which also worries me indeed, to what extent we are really efficient in screening our patients for cardiovascular risk. Questions from the audience? For when I understand right in this case, I'm thinking about this. That is, firstly, it is the awareness whether cardiovascular risk factor is there in your patient. So that's the first step the dermatologist has to do. But then the dermatologist, he makes that step, and then he just does the regular screening, and with the regular screening, then he says still a very healthy person, no problem. But then you go one step further, more in depth, and maybe you ask better in the family, and then it appears that an uncle also died at the age of 57 for a cardiovascular risk factor. So there is something like awareness, and then what is your protocol? To what extent do you adapt your protocol when a patient has psoriasis as compared to the normal screening for cardiovascular risk? So what is your advice for practice, for screening? What should we do as dermatologists?
Yes, it is always difficult to find the appropriate way, but I would try to take into consideration this algorithm, because it includes appropriate LDL levels, the family history, the BMI, which many of our patients are here, and they only suggest to refer to someone else who should be educated on this, because I've shown before in my country, many primary care physicians are not aware about this, and just considering this like to be strict on these issues, because many patients happen that they are like 45 or 47, the LDL is just a little bit elevated, but he's too young, they think.
In how many guidelines is this incorporated?
What?
Psoriasis, this scheme, the screening, you think? Is it there many guidelines there? Is it the Spanish guideline I like, for you have a good overview of screening for cardiovascular risk factors. But is that so detailed?
No.
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 And you feel that the steps should be undertaken, for evidence is accumulating, to adapt the guidelines that we are screening in this way.
Yeah, I think that's the next step.
That's good to make that position. For that are things that the dermatologists, we should discuss this together.
Yeah.
And your lesson from your case is that often when we do it too superficial, we miss actually miss a serious situation. Any comments? Yeah? Yeah, Tune. Yeah.
Thank you for presenting this very interesting case. I must say this patient is really, really fortunate to have met you, the dermatologist, because even if he had gone to the primary care site, his Remington risk score is still not high enough for him to be given a coronary CT. So he's in fact very, very fortunate. So I think for the whole day, since Chris' lecture, the most important thing is still lifestyle modification. Because if you look at this patient, his BMI is high, his LDL is high as well. Mm-hmm. Is it LDL? Yeah. Okay. Because if you look at the study, I hope this patient actually is classified under mild to moderate. So the mild to moderate, they don't have a risk of mortality, but they have a risk of diabetes, but not the cardiovascular risk, because the cutoff that I hope used was a BSA of 10%. your patient from your photo and the PASI of 8 probably have a BSA of less than 10%, right?
Yeah.
So I think Peter's point is very important. A lot of us are now revising our CPG, so we should actually include more specific instruction on how to pick up cardiovascular risk in our patient with psoriasis. Is that what you're suggesting, Peter?
Yes,
Yeah.
that's right. I think we have to discuss that to make our point also in the guideline development, that these aspects are taken care of.
Yeah, because they are, even the cardiovascular group, they are talking about going straight to coronary CT.
Yeah,
Yeah.
I agree. Thank you so much for this nice presentation. Thank you.